Hi. Good afternoon. Welcome to Cardiovascular Medicine Grand Rounds. It's my joy today to be able to introduce Ajay Kirtane. I'm going to save you rereading his CV for you. Let me just tell you, trust me, it's incredible, right? There is one glaring gap, though, is that up until yesterday, he had never actually been to Ann Arbor, Michigan. But I'm going to tell you two things that are not on his CV and just kind of share them with you. These are just reflections. The first is that Ajay is one of a dying breed. He is a true triple threat. What do I mean by that? I mean, clinically, he's not just seeing patients on the podium or in panels, right? He's grinding and struggling like the rest of us. The second thing is, I've always admired his research. It's very focused in the space of interventional cardiology. And he actually asks very interesting and focused questions that have kind of moved and nudged the field forward, which has really been just a great gift to all of us who practice interventional cardiology. And then the third thing is, as an educator, he has had an incredible influence. He's been the co-director of the Cardiovascular Research Foundation's Fellows Course, which is just been a real blessing and has trained really generations of interventional cardiology fellows. And that brings me to my second point, which is that interventional cardiologists are a peculiar group. We all boil at different temperatures. And in a field that's oftentimes highlighted by ideologues and mavericks, Dr. Kirtane, he is an Iceman. And I say this in the most positive way possible. The thing about it is that, you can find a number of people who'll tell you like the coolest new toy that they got their hands on, or how they did this crazy procedure in this wonderful way. But what Dr. Kirtane brings to the table is really a thoughtful and conscientious understanding of like, why are we even doing this? And what benefit is it bringing to the patient? And the funny thing is, people actually listen to him, and that's in large part because of his reputation. And in that way, he really does remind me of Eric Bates, and that's about the highest compliment I can give you. So, Ajay, thank you for making it to Ann Arbor and fixing that glaring omission in your CV, and we all look forward to learning from you.
Well, thanks so much, Brahmaji. And I have to say, it was too long. One of my cousins went to Michigan, and he kept extolling the virtues of Ann Arbor, Michigan, and everything else. And I kind of was like, yeah. And I'm not like just a New York-centric guy. I actually like experiencing all parts of the country and world. But I don't know why I never came here, and it's super amazing. So everybody keeps apologizing it's too cold in the winter. I actually think it's really pretty. And so thanks for having me. And for me, training at a variety of places, I always thought that the most effective grand rounds were those that didn't just focus on evidence, didn't just focus on trials that I or others have published, but were ways of taking patients, doing rounds, taking patients and their scenarios and using evidence to inform our care of those patients. And so I've sort of fashioned this way. Chronic coronary syndromes or coronary artery disease is really prevalent. So I've done this talk with, my parents in the audience and folks that are not really medical, and hopefully there's something relevant to everybody, because it's really the journey of how I started practicing, how I've learned through practice, learned through applying the evidence, and hopefully be able to tell you how I like to think about those patients that present with these types of syndromes. So thanks again for having me, and hope this is interesting. We'll definitely have time for questions at the end. I have a number of disclosures. I list absolutely everything on this slide. I was telling Brahmaji yesterday, someone on social media trolled me for not disclosing things. This is every study that I've involved with or whatever, and hopefully you'll see that they're not really that germane to this talk. The main thing is I'm an interventional cardiologist, and so what I talk about will be focused in that way. But I'll hopefully, there's some trainees in the audience, point out to you that I think being an interventional cardiologist is awesome, because not only can I intervene in the lab, I can also intervene in the office. I can intervene in patients' families, their lifestyle, and that'll come throughout the talk as well. So, when I first started practicing in 2006, soon after that, I was referred this case, and there's a woman who had multiple risk factors. Her EF was down a little bit. She had a CTO of the right coronary artery, had an ICD placed, guideline-directed medical therapy for heart failure, and was referred to our center for advanced heart failure therapies, i.e. LVAD transplant or stem cell therapy, despite, because of worsening dyspnea on exertion. And our heart failure colleague called me up and we collaborated. And one of the best things about being in an academic center is that you really can collaborate across specialties, and said to me, before we do that, I think the patient needs a cath first. And it was really curious to me at the time, when I got that phone call, I was like, I wonder why that patient hadn't been cathed in the community with progressive symptoms, known heart failure, known coronary disease. And I think one of the reasons for it was because there was this paradigm. When I came out of fellowship, right after that, the COURAGE trial came out. We'll talk a little bit about that. But there was this paradigm that less is more. In other words, as patients, no, by saying no and not getting cath, not getting procedures, not coming to the center with all these people who are predators because they just want to do the cases for a variety of reasons, you can save your own life because you're going to get avoidance of an unnecessary procedure. And by the way, you'd also save the healthcare budget, which was spiraling out of control and still remains to be the case. And so as an interventionalist, young interventionalist having trained, this was tough to see because I was sort of like, people are just directly, pointing the finger at us and saying, what you do is wrong. And I was wondering, and initially, like with all stages of everything, you feel, okay, this can't be right, this is wrong. But there was some pretty important data out there that showed that, we really were treating people very differently based upon where they were. Irrespective of adjusting for age and comorbidities and things like that. There's some regions like Florida down here, even some parts of New York, where there's a ton of PCIs being done. And there are other areas where there's no access, but even if there were access, there were less PCIs being done. And there was this variability in care and practice. And it takes a strong person to look internally focused at your own field and recognize the fact that there was probably cases going on, a fair amount of them. Brahmaji's been very involved in this as a quality initiative, and others like they're back there as well. We were probably doing cases that didn't need to be done. And I would pejoratively call them shamuloplasties, cases where patients would have an OM2 stented and somebody would go to the patient and say, I just saved your life. Whereas in fact, that probably wasn't true. And so societies came together and they came up with what were called appropriate use criteria for coronary revascularization. And at the time, many interventionalists felt that this was just, external scrutiny and why is this happening and all of this stuff. And the reason it was happening was because it was important to identify those patients that could benefit from revascularization and perhaps offer revascularization to them and not give it to those that didn't need it. And what you saw in the years after that happened, as I started, in my career, was that the rate of inappropriately rated procedures went down. The rate of appropriately rated procedures went up at the patient level and at the hospital level. And some of this, if you want to be cynical about it, was due to coding, people starting anti-anginals and then doing what they wanted to do anyway. But I legitimately think that there was a lot of education that went into this, and trainees now who are coming out in practice are a lot more thoughtful about what they're doing than some of the folks when I trained. And so this was all a good thing. But what was interesting to me at the time, as I started getting interested in this, was that if you look at the earliest cases of appropriate use criteria and the models for this, using what's called a modified Delphi model, they were not designed to identify overuse. They were actually designed to capture underuse of procedures. So this was from LA County. On the right-hand side is a chart review, patients who need revascularization because they have severe symptoms or anatomy. And if you don't get it, that was associated with a much higher rate of mortality than if those patients did. The whole idea here was to make sure that patients were appropriately getting the care that they could need based upon symptoms and anatomy. In addition, there were registry studies that came out. This is from the Get With the Guidelines registry, or Action Get With the Guidelines, that looked at patients who presented to the hospital with non-STEMI and multivessel disease or left main. And this is, true indications for revascularization. You have a non-STEMI, bad anatomy, and there's some hospitals, every hospital is here represented by sort of a dot, that are treating those medically 30 to 40% of the time. Now, maybe some of those patients are 90 years old and don't want anything done, and it's not appropriate, and that's fine. But is that really happening 30% of these patients that they see, or are they not adequately trained to be able to take care of these patients safely and effectively? We had a fellow, Darshan Doshi, who looked at just heart failure. Remember, in the Northern Hemisphere, the most common cause of heart failure is ischemic heart disease. And we just asked the question, forget about revascularization, how often are these patients getting a workup to determine if they have coronary artery disease, either a stress test, stress echo, anything like that. And within 90 days of an incident admission for heart failure hospitalization, only 27% were even getting a test to diagnose that they had coronary disease as the etiology. So you could say, well, this was criticized. Maybe, you know, it's just claims-based reporting and that kind of thing. So double that rate. Let's say we underreported by half and make it 60%. That's still too few people who are even getting the diagnosis of coronary disease when they present with heart failure. And why is it important to diagnose coronary disease? Well, the reason is because there's actually, forget about revascularization, a greater adherence to and prescription of guideline-directed medical therapy if you diagnose coronary disease. So for example, if you take a patient with heart failure and you don't diagnose if they have coronary artery disease, what's your LDL target for that patient? It's going to be different than if you actually diagnose coronary disease. And so these things can matter. And it's not just cholesterol-lowering medications, it's other medications as well. And so I became interested in this phenomenon that at the same time there was all this external scrutiny on overuse. Perhaps we were not appropriately using these techniques like revascularization for the patients in whom it could benefit. And so for me, I've always been patient-centered in my approach. And you know, this I borrowed for Roxana Moran. You want to really take the right patient for the right reasons, revascularize them, you know, based on ischemia. And in that way, you could optimize their outcomes and costs. And this rubric or this schematic is a theoretical one. But what I'd like to do is show you some data to support where the appropriate role of revascularization would be. And so the way I would do this is I divide it into two categories. One is symptoms and quality of life, and the other one is prognosis. And as an aside, this is often referred to as soft endpoints and hard endpoints, despite the fact that like high sensitivity troponin, I'm sure Eric would agree, is like one of the least hard endpoint that there is. But it's weird that we talk about quality of life and the way the patient feels as a soft endpoint and these infarctlets as a hard endpoint. I think it's somewhat pejorative to think about it that way. So let's talk first about symptoms, then we'll talk about prognosis. So this is from the New York Times, 2018. Heart stents are useless for most stable patients. They're still widely used. Why are so many people agreeing to an expensive procedure and putting themselves at risk for a placebo effect? So where does this come from? Despite the fact that historically there have been plenty of studies looking at anginal relief with either PCI or surgery, and I'm going to talk about revascularization as a whole, so sort of equating the two of those. The reason this happened is because there was a study that came out in 2017, presented to the TCT, a meeting that we organized. It showed that if you took patients that had stable ischemic heart disease in England and managed them, you know, with medical therapy aggressively, the increment that they could make with exercise after you did a PCI versus a placebo PCI, so you take them to the lab and didn't actually do the PCI, was not that great. In fact, the patients that had PCI did exercise a little bit longer, but it was not different than those that didn't get the PCI itself. And that's where that headline comes from. In fact, that wasn't the only headline. I'm sure many of you here remember it. Patients started calling, et cetera. But there are headlines like, unbelievable, heart stents fail to ease chest pain. Heart stents don't actually help treat the chest pain where the patient's clustering his chest, having an acute MI, which is very different than what they investigated. On average, in the UK, in order to get to the cath lab, they had to have 8 months of symptoms before they got there. And then thousands of heart patients that get stents that may do more harm than good. Finally, this sort of more ethereal placebo effect of the heart with this existential thought behind it. So it's important to not dismiss ORBITA. As with every evidence-based medicine study that comes out, you need to incorporate it into your overall thinking of how to treat patients. And so there were many interventionalists who just trashed the study. They trashed the author of the study, Rasha Alameh, you know, easy target. She's out of her fellowship. This is her PhD, all kinds of other stuff being said. Little do people know that she actually trained and did PCI with Antonio Colombo, who's like one of the fathers of interventional cardiology, and she's actually quite a good scientist. But what's important is to recognize who these patients were. So first, they could wait eight months. Second, it was single vessel disease, and many cases were physiologically negative. They actually did a blinded physiologic assessment, and many of the patients didn't actually have abnormal physiology. Interventionalists said, oh, that's ridiculous. How could you treat those patients? Well, in reality, physiology is used in a small proportion of cases. This is how people treat patients all the time. So it was actually real, and they published every angiogram showing that these were real disease. And what was seen is that if you intensified medical therapy on an average of 3 anti-anginals, patients had pretty good symptom control. They had angina about once a month. They had good exercise capacity, VO2 max, and minimal ischemia. But in those patients that are frequently treated in clinical practice, or were at that time, there was not that great of difference between PCI and just managing them medically or a sham procedure. But what's really great about the ORBITA study investigators, Rosh is one of them, but the whole team, was that they tried to understand this a little bit better and try to figure out, well, this doesn't jive with routine clinical practice because we see many patients who get better after we put a stent in. So how can we reconcile this? So one of the things that they did is they did a study where they took patients to the cath lab and exercised them. They showed that they had a physiologically significant lesion, and then they revascularized them. And then they exercised them again. And the second time around, they incremented their exercise capacity by about a minute. In ORBITA, it was only about 20 seconds or so. So what's the difference? Well, number one, these were physiologically significant lesions. Number two, the patients knew that they had been revascularized, and so they likely were more unfettered in terms of their ability to exercise. And what was interesting is that in this study that they published in JACC, in the beginning, all the patients, virtually all of them, stopped due to chest pain. But once it was revascularized, they all pretty much stopped due to physical exhaustion associated with an increase in lactate. So there was a physiologic effect to what we were doing if we picked the right patients. In addition, the investigators went back to the ORBITA study and looked at getting patient completely angina-free. And what they showed is that was more frequent among those that were randomized to PCI versus the sham procedure. And so this was significant. They further did another study, ORBITA 2, which was recently published in the New England Journal. And beyond getting kudos for doing the study, Rasha, I think personally also deserves kudos for actually allowing the fellow who did it to be the first author and presenter of the study, which is something is unheard of in academic medicine. But in this study, where they actually took patients off antianginals completely to avoid that confounding effect of medicines, what was shown is that PCI clearly reduced symptoms compared to medical therapy alone, or the sham procedure. Finally, they've done additional studies, this was published last year, where if you take a patient before you do the PCI and ask them what their symptoms are, and then during the balloon inflation, you reproduce those symptoms, those are the patients most likely to have a benefit. And it's important to emphasize that because that's why history taking is so important. So I'll ask a question to you. It's noon, so there could be some postprandial stuff going on. So number one, the orbital program results are most consistent with the following statement. Number one, and this was the view espoused in the editorials at ORBITA when it came out in the Lancet. There's no role for PCI for patients with stable ischemic heart disease, and it should be class 3 in the guidelines. That's literally what was written in the editorial. Number two, the symptomatic benefits of PCI over maximal medical therapy are modest for patients with single vessel disease. And number three, this is the gung-ho interventionalist view, PCI should be the default therapy for all stable ischemic heart disease patients with angiographically severe lesions. I think most of you have recognized, and Brahmaji gave the teaser of what kind of clinician I am, it's going to be in the middle, and it's really the second one. We have to recognize that we can't benefit everybody, but we can benefit those patients who really need what we're going to offer. And remember, symptom improvement is going to correlate with the nature of prior symptoms. So how do we ascertain prior symptoms, and can we be better at doing it? Yes, and I'll show you a slide to that effect. But importantly, what we're going to talk about is a little bit about what the therapy alternatives are for patients. If you look at earlier versions of the guidelines, what they often say is you ought to try sublingual nitro, a beta blocker, calcium channel blocker, or ranolazine. And if you fail all those things, then you would consider revascularization to improve symptoms. So if I take somebody that's having angina, like every time they walk from here to there, this is what I'm supposed to do. But the reality is none of these agents, beta blockers, nitrates, calcium channel blockers, or ranolazine, change prognosis at all. None of them affect prognosis. They only affect their symptoms. And as a practical person, if you're going to try to push medications on a patient, patients are only going to take X number of medications. We know this kind of for a fact. And what's interesting is that in those guidelines, they do talk about aspirin, statins, and lifestyle modification and other agents like that. But we can't really force people to take 6 or 7 medications. So from a practical standpoint, this becomes a bit of a challenge. In addition, for those that have significant symptoms, if we revascularize them either with PCI or CABG, all randomized studies have shown that you can treat with less medications to basically get the same or better symptom benefit. So we had a conversation this morning amongst the fellows. Do I actively de-escalate antianginals? The answer is absolutely yes. If I have somebody who's on antianginals, after I revascularize them, I stop the beta blocker, I stop the calcium channel blocker because they don't need them. And I have to be honest, many patients have a better symptom benefit from stopping the beta blocker than they did from the PCI itself, especially younger patients. The second part of this is this has been studied in multiple trials. And if you look, for instance, at the ISCHEMIA trial, where they took patients who were largely less symptomatic, and randomly assigned them to a cath versus no cath. It wasn't revasc versus no revasc. It was cath versus no cath, and followed them over time. What was really interesting, and this is from John Spurtis, he showed that it really depended upon how symptomatic the patient was at baseline. And this is what we do in clinical practice. We don't just look at every patient and treat them the same way. We try to take those patients who are symptomatic walking from here to there and treat them differently from those that can get angina once a month. And so what was seen in this trial is based upon the severity of symptoms. If patients had daily to weekly angina, you really only needed to treat 3 patients with a cath to render them angina-free. If they had no symptoms at all, there was really no difference because you couldn't make somebody who was asymptomatic feel any better. What was also interesting and different from the COURAGE trial was that these reductions in anginal symptoms were actually durable over time. And so if you look, for instance, at patients that have daily to weekly angina, there's no question within the ISCHEMIA trial that those patients have the best benefit in terms of their symptom reduction. This is despite the fact that there's less anti-anginals. So not only do they feel better, but they're on less anti-anginals, although there is more dual antiplatelet therapy. So as a clinician, you have to weigh those options. If the patient's at high bleeding risk, maybe that's a different decision that you take. In fact, within the trial, there were many patients who were randomized to medical therapy that never got a cath. And then there were those in that arm that crossed over and had a cath. And then this analysis that was published earlier this year, what was interesting is the strongest predictor of having to go to the cath lab if you were initially randomized to medical therapy was the severity of symptoms. If you were having very frequent angina, why would I mess around with medical therapy? I would just cath the patient and then treat them appropriately. And that was what was seen in the trial. Now, as clinicians, we're all busy. And it's very, very difficult, especially as we're burnt out and things like that, if you're an internal medicine physician, to spend all that time in the visit ascertaining what's going on cardiac-wise. And what I mean by that is, as an internal medicine resident, I used to hate clinic because I had to do everything in 15 minutes, and I never got a chance to ask the patient about their family or things like that because I had to do the healthcare maintenance. I had to ask them why they were there. And then when we were finished, they always had another question. I think this is a common thing in clinical practice. You always finish with the visit, and there's a question as they're walking out the door. So as an interventionalist or as a cardiologist, one of the best things about subspecialty medicine is if you're good, you can cover the entire history in a very short period of time and then spend the last 5 minutes talking about what their kids are doing, what happens over time. And as an attending, I like clinic much more than I did as a fellow or as a resident. The other part of this is that many people think of the history taking as, do you have chest pain? And the patient says, well, no, I don't really have chest pain. So what I do now is I say, well, tell me what the things that you do. And they're like, I like to walk the dog. So I always ask them, I have a dog. I was like, okay, what's the size of the dog? In other words, does the dog walk you or do you walk the dog? And those types of questions can really get to the point, well, actually, you know, I used to have a bigger dog, but I couldn't keep up with it. Or I used to walk the dog, but as I can get to the end of the driveway and that's it. Now that could be COPD, that could be a variety of things, but those types of questions are really important as a good clinician. And as a specialist, you actually have the time to talk about it. That having been said, there are studies on this. Suzanne Arnold published this paper in the Procedural journal. I'll call it your journal because it is your journal. But really interesting. What they did is they asked patients, are you having angina based upon the Seattle Angina Questionnaire, a validated instrument? And then they asked those patients' doctors, is your patient having angina? And on the left of the slide was 100% concordance. Each of these bars is an individual doctor. On the right of the slide are physicians who, or clinicians who 80% of the time don't recognize the patient's actually having angina. Now, they're not bad doctors. They're probably too busy or they're probably not asking the right questions, but there's a huge variability in practice, and it really is important to take the time and effort to understand exactly what the patient's feeling and to be honest with them about your expectations for what might happen if you revascularize it. You can tell people, I'm going to make you feel better because we opened up this lesion. But we all know that that's not always going to be the case. So you have to take the time and effort to do it right. And there is a lot of variability here. So training is important. So as an example of what can often happen to patients and the benefits that we can achieve, this is a patient who basically came to see me. He had an EF of 30%. He basically had severe angina, less than 1 block of walking. He had had a prior cabbage and had been medically managed. There was inferior ischemia, and he's been escalated on multiple meds and came to see me for another opinion. And he had a CTO of the right coronary artery. I'm not going to show you the left anatomy. And he had a REMA to the RCA. but there's this hazy thing at the anastomosis of the rema. And so I said, this is kind of interesting, but he's got inferior ischemia. There must be something going on here. And that's sort of it zoomed up there. So I thought initially, somewhat probably naively, that I would do IVUS on this despite the bend. I don't think IVUS is the right test for this, but I couldn't even wire it initially. The wire just wouldn't get through this thing. And ultimately, the only way I could wire it is I actually bounced with a hydrophilic wire off the top of the occlusion and down the vessel, and then ultimately ended up treating it. And this is what he had. He immediately felt better. We de-escalated antianginals. And when you treat real patients with real symptoms, after you basically get letters like this: I thank you for all your help. It's a great feeling to be angina-free. Your grateful patient, who, by the way, is on less medications because I de-escalated. The problem is if you stent everybody, even those that have no symptoms, you're not going to get these types of effects. You really have to take care of the patients that are the most symptomatic, and you have to take the history to figure that out. So this is supported by the guidelines. It's class 1A to treat patients that have refractory angina despite medical therapy. I actually think that this should change after ORBITA 2 to not just refractory angina, but as a decision for the patient. Do you really want to be on 3 antianginals, or would you rather be off antianginals? But nonetheless, it's class 1A to revascularize to improve symptoms. But it's super important to remember we don't have to revascularize everybody. And just like that patient sent me a note, they'll also get notes from patients who are referred with a CTO, and I told them that you don't need this open because you're totally asymptomatic and fine. So why was the patient so concerned, and why did they write me the note? It was a great visit, one that was very important to me and my family. Why was it important? Because I explained to the patient, who was deathly afraid that he was going to die because he had a chronic total occlusion, that he wasn't going to die from the CTO because the artery was already occluded, and that the other vessels looked okay. He was minimally symptomatic, and there was good evidence to support managing him medically. So just like you get those other letters, you get these letters too. So moving on beyond symptoms, because I do think now, especially with ORBITA 2 having come out, most people do agree that you can improve symptoms. Even the true naysayers would agree that you can improve symptoms if you pick the right patients. Let's move on to the more thorny issue, which is prognosis. Can we improve outcomes of patients with stable ischemic heart disease or chronic coronary syndromes by revascularization? I would dare say that if you go to most medical schools right now, and you ask this question: if you have stable disease, can you prevent deaths? Can you prevent cardiac deaths or myocardial infarction? Everybody is taught, no, you can't. It's all about the symptoms for the most part. And I want to question that a little bit and show you some data in that regard. But before I do that, I want to emphasize that, especially for prognosis, it is super important to emphasize diet, smoking cessation, aspirin, statins, aspirin for the right patients, blood pressure control, and all of this. The reason I say that is because many people paint interventionalists as people who only like to spend time in the cath lab. And for me, interventional cardiology, the reason I liked it so much was it was because we were intervening, period. And that intervention could be in the cath lab, it could be in the office. One of my best patient stories is a guy who kept coming into the hospital, and he went through gastric bypass surgery before they were GLP-1 agonists, and immediately stopped coming to the hospital because his glucose was controlled, his LDL got controlled, and he just felt better. So interventions that work are interventions that we can all get behind. And so, in fact, this past year at TCT, we made the byline of what's historically a super interventionally focused procedural meeting from intervention to prevention. And the idea is we have to be better at prevention as well as interventional cardiology in order to be good doctors. The reason this is important is because studies like COURAGE have demonstrated that if you can get more patients at goal, that's associated with a much greater chance of survival. If you can control all these things, those patients do much better, not just in terms of symptoms, but in terms of survival. But we're pretty bad at it. There's legislation that's really helped in terms of smoking cessation, but things like blood pressure, physical activity, lipids, and BMI control in the US is terrible. And the BMI, for the first time, is actually getting a little bit better with GLP-1 agonists. But physical activity, if I'd ask everybody in this room, do you have a plan for what workout or physical activity you're going to do today? Raise your hand if you do. So that's why you all look great here in Michigan. Like most rooms, like 2 people raise their hand because we're too busy. But it's much better as a clinician to be able to talk to your patients about what you do than to then convince them than if you're just kind of faking it and say, yeah, you got to be more active. So for instance, if a patient comes to me and they say, I like to work out, I like to run. I'm like, what kind of times do you run? Do you run races? Like how fast do you run? I was joking this morning that I have a lot of South Asian patients, and I actually asked them, so I like to walk. Okay, how fast do you walk? Do you sweat? They're like, no, I don't really sweat too much. I said, listen, you know, do you walk like an Indian auntie, which is like, you know, looking around at the scenery? Or do you walk like an American with weights in your hand going like this, getting a workout? And everybody can understand those things, but those questions are important to get people to adhere to what you want to do, because that's going to change their prognosis. We are really bad at this. If you look at medicines like statins, the proportion of patients with established ASCVD that are on no statins is like 50%. And it's even worse because of like the TikTok, Google misinformation that's out there about statins. Thankfully, there are other agents now, but you got to spend a lot of time in the office and even in the cath lab telling patients, okay, we treated whatever we treated, but we need to fix the disease. The fire is still burning unless we put it out. And the way we put it out is by these preventative therapies. Now, if you go beyond that and talk about revascularization, that's where people say this becomes more controversial. And so The Atlantic is probably one of the best things that I read nowadays. I really like The Atlantic. And this was written in 2017 by David Epstein, who wrote things like The Sports Gene. He's a super smart guy. And stents for stable patients prevent 0 heart attacks and extend the lives of patients, a grand total at not at all, when evidence says no, but doctors say yes. I was so mad when I read this that I actually emailed David Epstein and said, listen, I think you're just overgeneralizing this data. This is more nuanced than that. And he said, and so we actually engaged in a little bit of back and forth. And maybe I'm stupid for doing it, but I like literally feel strongly about this stuff. And so I actually sent him a version of this talk. I was telling Edie that I sent him a version of this talk that I had given previously, and it was on YouTube. And I said, just listen to this if you're okay with it. And this will explain it. He actually told me it was interesting, and it, you know, nobody's going to retract anything, but that's fine. But at least he listened to it, and it was a great conversation. But where did this come from? Well, the reason it happened is because there's studies like the COURAGE trial, which randomized patients that had stable ischemic heart disease to medical therapy versus medical therapy plus a PCI to see if you could improve death or myocardial infarction. And there's no difference in terms of the outcomes among those patients that were in the trial. Interestingly, when I was a fellow, I never told patients we were going to prevent heart attacks by doing a PCI procedure or a surgery. I always said that it's predominantly for symptoms. And in fact, there's an increased risk up front because we're intervening on your coronary artery. So where am I getting this theory that we could perhaps improve outcomes? Well, there's a few things that I'll show you. First, observational, then randomized. So number one, diagnosing and treating severe coronary artery disease is prognostically important. This is actually a fact and has been born through history. If you look at early studies before we had nuclear stress testing or anything like that, if you had severe disease, you did worse. And so really what we're trying to do in clinical practice, if I'm seeing 20 patients a day, is I'm trying to figure out who's the patient amongst those 20, the 1, 2, or 3 of those patients who have horrible multivessel disease or left main disease, because those are the ones who I might be able to benefit. And I borrowed this from John Spertus. The idea is when you do a clinical trial like COURAGE, there are going to be a bunch of patients that have a good outcome with the PCI, the randomized strategy. There's going to be some that have complications, and then there are going to be others that you didn't really benefit. And when you look at the overall results of a trial, you get an average treatment difference that's basically across all of those patients. But what we really want to do as clinicians is we want to risk stratify them and apply those effective therapies to the patients who could benefit the most. We want to separate out those that are going to have the benefit and offer that to them. And those that are going to get harmed, obviously, why would we do a procedure if we could figure that out in advance? So the real question is, can we figure that out? So there's a few streams of important data. And just historically, the idea is that if you have severe anatomy, that can dictate your outcomes. And so if we think of a 55-year-old woman who comes to see me, and she's just in the office, she has some mild symptoms or something like that, but I don't know what her coronary anatomy is. She could be sitting in front of me with 3 vessel disease and a 95% proximal LAD stenosis, and she has a 4 in 10 chance of dying in less than 5 years before she reaches 60. She could, with the exact same symptoms, be sitting in front of me and have single vessel disease, even a 75% lesion, and she has a 9 in 10 chance of surviving those next 5 years. So wouldn't I want to know what her anatomy is in order to treat her if I could change this prognosis? So this is true not just then, previously, this is all seen in the CAS registry, et cetera. In fact, if you think about stress testing, historically, the whole idea behind stress testing was to try to predict who had high-risk anatomy. Obviously, it's gotten much more sophisticated since then. You can do regional parsing out, and certainly in places like this and other centers, you can do a lot more. But the whole idea was to predict the high-risk anatomy because we knew those people did worse. This is a more recent CT study within Denmark. And if we look, it's not just the extent of plaque that you see, it's the extent of plaque and also if it's obstructive that then determines prognosis in terms of MI or death or myocardial infarction. There are clear gradients that are seen in terms of observational studies. What does this mean? This certainly means we have to be doubling down in terms of the medical therapy, like lipid-lowering therapy, et cetera, to goals that are different than we see in primary care. Oftentimes, if you talk to a patient, they say, my internist thinks my LDL is fine. I was like, what's your LDL? Nah, it's 95. I'm sorry, if you have extensive disease, 95 is not good enough. You got to go more than that. But what's important is that the prognosis really starts to escalate, not only with multivessel disease, but how severe the stenoses are. It's not just the 20%ers that rupture and cause problems. If you have a 20%er that ruptures, it will cause a problem more if you have multivessel disease than if you don't. And so really, why is there this proscription against coming to the cath lab and figuring this out? We're doing a CTA. So we have to, again, look at ourselves and understand what's happening. This paper for me was a really, really important one that I found soon after I started being attending. And this is the rates of disease seen within the US in New York, so that's where I'm from, versus Ontario. And why is the difference important? Well, because Ontario is a health system where it takes a long time, like the UK, to get to the cath lab. You don't just show up in the cath lab because someone did an executive stress test, read diaphragmatic attenuation as inferior ischemia, and said, you need a cath because you're going to die. That's what happens in New York. And so if you look at the bottom line of this slide, the incidence of left main or three vessel disease in New York is like half of what it is in the system where it takes a lot to get you into the cath lab. So the reason why we have guidelines that are so prescriptive is because if we cath all kinds of wrong people that don't need the cath, of course you want to be more prescriptive because you're going to treat people who don't need to be treated. On the other hand, if you have an enriched population, now you're starting to focus on the patients that actually could gain from something that could change their prognosis. So why do I say could change their prognosis? Well, it turns out there are studies in left main disease. These are studies looking at this. Very few patients randomized to show a mortality benefit from revascularization of left main disease with surgery. There are other studies, older studies, looking at multivessel disease, CABG versus medical therapy, showing a prognostic benefit. This is a seminal meta-analysis by Salim Youssef. I like putting this graph because it shows you how old the study is. And the reason why I want to show you that is because the immediate counter-argument is, well, these are really old studies. So what about with modern therapy? Like, this might not be the case anymore, right? Well, so the most recent study that we can use to inform our practice is the ISCHEMIA trial. So ISCHEMIA was designed with the hypothesis that just by cathing somebody versus not cathing somebody who had a high-risk stress test, we could improve outcomes. And the original outcome for ISCHEMIA was going to be cardiovascular death and myocardial infarction. So a massive NIH-sponsored study, and unfortunately could not enroll to the full cohort of 8,800 patients. And so they actually changed the endpoint and randomized 5,179 patients. Those patients were randomized to the invasive arm, cath, versus a conservative arm, and they were followed for only 3.3 years at median follow-up to start off with. One of the things that the ISCHEMIA investigators were very concerned about is if you take somebody with a high-risk stress test, what if they have left main disease? We can't randomize somebody with left main disease with that clear mortality benefit. So what they did is they did a blinded CTA. So the investigators couldn't see the results, but if the patient had left main disease on the CTA, excluded from the study. So how frequently did that happen? Because that's important for your clinical practice. If you see somebody in front of you of a high-risk stress test and you want to manage them medically, you know, if they have a high incidence of left main disease, well, maybe you ought to do a CTA first. And it actually happened 8% of the time that they were excluded. Because patients with chronic kidney disease couldn't get the CTA, the true prevalence of left main disease unselected from these folks is probably around 10%. And that's actually a lot. So I would say if you're going to apply the trial in practice, you probably should do this type of analysis to make sure they don't have left main disease. So what did the results show? The primary outcome most people are familiar with, really no difference between the arm of going to the cath lab versus those not going to the cath lab. And of note, in those ones that went to the cath lab, not everybody got revascularized. About 3/4 of them got revascularized, 3/4 to 80%. But if you look at the endpoint that the trial was originally designed to investigate, and that's cardiovascular death or MI, what is not known about this trial, which is largely viewed as a negative trial, is that this is the endpoint of cardiovascular death and MI. And of course, up front, just like for the primary endpoint, there's a risk of going to the cath lab because we can do bad things to patients either with PCI or with surgery. But not only do the curves diverge, but at 4 years, there's a statistically significant reduction in cardiovascular death or MI with the cath arm of the trial, despite the fact that 25% of patients didn't even get revascularized. So I'll repeat that. In the ischemia trial, there is a significant difference in favor of the invasive arm in cardiovascular death and MI. I would bet that most people don't know that. So why is that? Well, we have to be, investigating this further and try to understand, well, how are we reducing cardiovascular death and MI? Underpowered, yes, but yet it's a finding. Well, it's interesting, but there's actually studies showing that we can reduce spontaneous myocardial infarction with PCI and also CABG, by the way, although there's an upfront risk of causing an MI. So if you just look at spontaneous MI, there's a reduction. And within the ischemia trial, you could say, well, that's just garbage. These are type 2 MIs. It doesn't really matter. It actually turns out it's a reduction in type 1 MI. This was published in, I think, Circulation. And it didn't matter in the invasive arm whether you had PCI, CABG, or just medical therapy alone. There is a lower rate of type 1 MI compared with the conservative arm of the trial. So some people ask me, well, how could the medical therapy treated patients have a lower rate of MI? And the reason is because those who were treated medically didn't need a revascularization, so they have a low rate of events. And those who were treated with either PCI or CABG also had a low rate of events because they were protected from these type 1 MIs. If you look in the primary analysis, primary paper in the New England Journal and the supplement, you'll see the difference in cardiovascular death or MI within the trial. And at 1 year, it's actually worse in the invasive arm because there's harm of doing CABG, doing revascularizations, et cetera. But at 3 years, it starts to favor the invasive arm. And at 5 years, virtually the entire distribution is on the side favoring revascularization or favoring cath. Now, it's not a massive difference, but it's a difference nonetheless. So it begs the question, so who are these patients that are benefiting and how are they benefiting? If we look at the follow-on publication, Ischemia Extend, it's a reduction in cardiovascular death, and it's predominantly observed in multivessel disease patients. So you're not going to save someone's life or prevent a cardiovascular event by revascularizing a distal right or a PDA or something like that. These are patients that have multivessel disease. Now, all-cause mortality is equal because there's an unexplained increase in non-cardiovascular MI. But what's really interesting, and this was published earlier by Shripal Bangalore, one of the investigators, if you had 3-vessel disease on coronary CTA within the trial, whether you got PCI or CABG, there was a reduction in cardiovascular death or MI, no difference in all-cause death, but also a reduction in angina. So prognosis is affected if you pick the right patients. And so I've given away the answer to this question with regards to the prognostic benefits of revascularization. Number one, there's no patients for which coronary revascularization has been shown to have a prognostic benefit over medical therapy. I would bet that if you pose this question on social media, the vast majority would answer yes to this. Number two, the prognostic benefits of revascularization are manifest in higher risk patients that take time to offset the procedural risk, which is real. Or three, coronary revascularization unequivocally saves lives for most patients, irrespective of baseline risk. I think you know where I stand on this. It's going to be in the middle. The key is pick the right patients, do the revascularization safely, because there's always going to be an upfront risk. I use the ischemia trial to my benefit. You have Epic, I have Epic. Epic can be a pain, your inbox is full, et cetera. This is my smart phrase, and my initials, ischemia. And it basically says, this is for patients that come to see me and deciding to cath or not. We had an extensive discussion regarding the risk and benefits of these therapies. On the basis of this trial, I don't see any prognostic benefit at this present time to rush to the lab and revascularize. I'd recommend medical therapy at the time with continued risk factor modification. Everybody's worried about the medical legal part. I did mention we can never predict the future. It is certainly possible that an adverse event could occur. However, I'm not confident that I could prevent this event from occurring with an evasive approach to the management this time, his or her, especially based upon randomized data. So I just type those words, the thing pops out, and I feel less burnt out, and that's why I have a smiley emoji up there. Now, the guidelines also reflect this. It's now class 2A in the guidelines in patients with stable ischemic heart disease and multivessel disease, to revascularize to lower the risk of cardiovascular events such as spontaneous MI, unplanned revascularization, or cardiac death. This is something I would never tell a patient before the ischemia trial came out. And And remarkably, from this trial, this is buried, and most people don't think about it this way. And I don't tell every patient this is what's going to happen, but I say for multivessel disease patients, the data is leaning in that way. Now, the problem is that what happens is we had this sort of lull in PCI with all the appropriateness stuff and courage. Now, all of a sudden, with ORBITA, this ischemia analysis, there's an increase in PCI. And instead of being balanced, what ends up happening is we start, there's nothing wrong with investigating this, having headlines like this from the PREVENT trial, treat vulnerable plaque, you can prevent MACE. So I want to temper that enthusiasm a little bit by showing you, again, how clinical trials can be misinterpreted. If you look at this trial, the PREVENT trial came out earlier this year, the composite endpoint was reduced with preventive PCI. So we're looking at lesions, they're not hemodynamically significant, they look vulnerable, we stent them versus we leave them alone. But at 7 years, there's no difference in death. In fact, it's only 7 events versus 8 events, very low risk population. There's no difference in myocardial infarction, 5 events versus 8 events. The entire thing is driven by revascularization over the follow-up period. That's what drives the composite. So what is being said is that you could stent them up front, but you could also avoid 782 revascularizations by not treating them up front with no risk of additional MI or death just by leaving them alone. So we really have to not get overly exuberant with some of these positive data. And this, to me, was totally misinterpreted. I see many people saying, oh, we should stent vulnerable plaque. No way. You can leave it alone in so many people, and they're never going to have an adverse outcome. So where does this lead us now? And I think this has been my area of study and interest, and it's really to focus on the highest risk patients. We wrote this white paper back in 2016 when this whole CHIP initiative was being formed, and no, CHIP is not clonal hematopoiesis. In the interventional space, it's something different. It's higher risk patients with an indication for revascularization. And our whole goal with this was to try to focus not on the OM3 minimally symptomatic, was to focus on those patients that were not getting revascularization for a variety of reasons. First, emphasize medical therapy. I spoke about this with dinner with some of the attendings last night. We looked at our own cath lab, those patients coming in for complex PCI, what proportion of them had LDLs less than 70? It was only 43%. So the ultimate teachable moment for a patient is when they're hearing about the results of their angiogram or their CTA. You can show them the plaque and you can say, yes, we fixed it, but the fire is still going. You need to be on lipid-lowering therapy. And there's plenty of studies showing that adherence goes up after a bypass surgery, after a PCI, or after a CT. And so one of our fellows wrote this viewpoint, and we made this case for inclusion of a lipid panel in the standard pre-cath lab draw. Everybody gets their creatinine, their INR, their CBC. Why don't we add lipids to that? Why don't we, when we do the cath, talk to the patient about getting their LDL at goal and actually make a treatment decision then? Because there's plenty of studies that show whatever we do in the follow-up period, nobody's going to change their medicines. Whereas now we could actually do it. And so this was, we call it stating what should be obvious. As far as the procedural aspects, these higher risk patients need additional training, expertise, judgment, and there are a lot of things you need to learn to figure this out. And so go back to my patient, he came back. He had a restenosis of this rheuma anastomosis. So he's already had it on a bend, restenosis. I could treat it a variety of ways, but one of the things that we thought to do, or I thought to do, is why don't we treat the native CTO? And remember, this is what it looked like. Most places don't know how to treat the CTO because where do you start? How do you support the guide, et cetera? But if you've trained to be able to do these cases, you can put a wire up, you can do dual injections. You see where the right coronary should be. You can put a wire up in the conus branch to stabilize the guide. You can anchor it with a balloon. You can go down subintimally and then use what's called antegrade dissection and reentry and re-enter this vessel, get in the lumen distally. And this was actually, honestly, my first ADR case I ever did, and restore native circulation flow. And again, the patient became symptom-free. The problem is not everybody can do this. If we look at the US numbers, 44% of operators do less than 1 PCI a week. If you do less than 1 PCI a week, it's going to be impossible to safely do a procedure like that. In fact, if you look at the highest volume cath lab in the world, which is the Fuwai Hospital in Beijing, they do 20,000 angioplasties a year. In that hospital, if you're a high volume operator or a low volume operator, your outcomes of cardiac death and just death overall are vastly disparate. And this is despite the fact that some of the higher volume operators are probably doing the higher risk cases. So what we do at Columbia is we have a model where none of us are sort of RVU based, we're all salary based. And so if you have a complex case, one of the higher risk operators will scrub with the primary attendant. You can still bill for it and everything is fine, but we want to have a regularized level of care, irrespective of who the patient is and who the initial clinician is. We want them, when they come to Columbia, to get the same level of care. It's important to recognize that different places are going to have different benefits with one therapy versus another. This is a famous slide from the Syntax trial, which is a CABG versus PCI trial. There were some sites, each individual site is a bubble here. There's some sites like this one that at the same site, the rate of adverse events with CABG was 40%. It was 10% with PCI. At this site, it was 50% adverse events with PCI, 0% with CABG. If you're the patient and you're at this site, what therapy do you want? We have to be honest with each other and ourselves to determine what our adverse outcomes are, what our strengths and our limitations are, and then be able to refer patients or consider it appropriately. And within the guidelines, there's several points that I would highlight. One is you got to spend sufficient time to talk to the patient, allow them for a second opinion, send them to somebody if you need to. You have to discuss the specific benefits and risks associated with it, and then provide information on operator expertise, volume, and total results as a whole. So to sort of conclude, a couple last slides, this kind of puts things together. This guy was very famous for one-liners, often at his own expense. And he underwent a stent procedure some time ago, and it was deemed an unnecessary procedure by pretty prominent people. This is American medicine at its worst. He's a poster child for inappropriate use of stenting. And the reason I think he underwent the procedure, and the reason I know this, I'm not divulging anything publicly, is that he was asked afterwards, what did you think of people saying this? He basically had a very severe proximal LAD. He's an avid cyclist and was asymptomatic, but got it treated. And so the question was, what did you think of these people saying this? And the one-liner, probably the best one-liner I've ever heard him give, was, they can say what they want, but it wasn't their LAD, right? So you could just imagine him saying it, frankly. But anyway, the point is that it has to be a personalized decision. And you can be honest with the patient and say, listen, I don't know if there's much benefit here, but I don't want you cycling like this in the woods with this subtotally occluded LAD, because who knows if what's going to happen to you. So there's that. So what did I try to attempt to convey today? Well, first, coronary artery disease and the clinical syndromes associated with should be treated with therapies that aim at symptom relief and prognostic benefit. And those therapies can be either interventional or otherwise. The location and severity of anatomic disease, the type and severity of symptoms, and patient risk will most often dictate the benefits of revascularization, informed by a healthy dose of common sense. Get your incentives right. Your job as a physician is to treat the patient, and it's a privilege to do so. So don't get the financial incentives or others mixed up in this. Interventional cardiology can be as cerebral as it is technical. That's what drew me to the field in the beginning. And we really like interventions that work, not just those occurring in the cath lab. And I would encourage the trainees to kind of embrace that as their mantra for how to be an interventional cardiologist. And I do think it feels great to think while practicing clinical medicine. It's what allows us to escape the sort of the doldrums of doing the same thing over and over again. And the ability to thoughtfully apply and communicate our clinical judgment, informed by the evidence base, which is evolving, is our fundamental responsibility as clinicians. So thanks so much for listening. Happy to take any questions at this time.
If this is working, yeah, great. Well, thanks, Ajay. Questions? I could start with one. Okay, Stan, go ahead.
First of all, thank you for a fantastic talk. And after 25 years in this field, makes me feel one question I had for you, definition of chip text, the human or locus, I can't find that. Sometimes it's in the eye of the beholder. It's a great talk. But clearly, the intervention field has advanced to a point where certain ancillary techniques, IVUS, OCTs, become really important. And how do we, as we become more adapted doing these procedures, spread this out to the community that a complete revascularization procedure involves an imaging modality?
Look, I think that some of it's evidence-based, some of it is just like, it used to be you could present cases at conferences and not show imaging and it'd be okay. Now you're kind of shamed into showing it, which is a good thing. The BMC initiatives are like great ways of doing this. I think this now with the evidence base that we have, there's enough out there that this will start to really, really go. And what I'm proud of in the US is obviously financial incentives to reimbursement would be great, but I actually think it's already tipped before financial incentives as well. And if you look nationally, this is really growing. And I think it's a good thing because the evidence is now out there that this is not just associative, it's actually causative. And that's a good thing for patients. And I think it will encourage folks to change their practice, just like radial, for instance.
I guess from what you can say, right? Within a decision by the faculty, we went from 25% to now close to 70%.
Which is great. And I don't think the right number is 100, by the way. There's definitely cases that complications can ensue, et cetera. But yeah, you have to sort of be judicious about
it. Even the old guys are using it. He's been really proud of that.
No, that's great. That's good.
Let me ask you a question while others are thinking about this. So, it's interesting to me. One of the things that's happened over the last decade is the number of, as imaging itself has just increased, and I'm talking about, imaging in general, right? Even non-cardiovascular imaging of the chest leads to coronary calcification being detected, leads to, and it goes down this line. And how do you think about incidental CAD and how it's found? Because we do know that the prognosis is so different based on a number of ways in which patients reach us.
Yeah, and look, I think CTA is a great way. You don't have to cath everybody. CTA is a great test. The challenge is that you kind of feel like you're reinventing the wheel because oftentimes CTAs I've seen read by radiologists, and the radiologist is telling the patient you need a cath, irrespective of their symptoms. And so I think it's just the way I view CTA is it's a super useful technology. What I'm using it for is to rule out left main or true bad multivessel disease. Everything else, you're going to aggressively push medical therapy, but whether you go to the cath lab or not, it's going to depend on what the patient presents with, symptoms or otherwise. I still think there's a real good value in exercise stress testing, with imaging as needed, because that gives a more objective assessment as does the dog walk you or do you walk the dog? But the latter is also important in terms of those types of questions.
Great. Any other questions? All right. Well, Ajay, thank you again for making your way to Ann Arbor. We really appreciate it.
Thanks for having me. Really a pleasure.